Thanks very much, Peter. PK, pleasure and an honor for me to be here today. Thanks so much for the invitation. Good afternoon, all. My talk is Novel New Devices for Carotid Artery Stenting. My disclosures, I do have one pertinent and one. Contigo Medical is a company I've founded. I'm going to be talking about some of those devices, so please keep that in mind as I make my comments. So, looking back 2 decades, from when carotid artery stenting first started till now, we've seen a steady drop in overall MAE events, death, stroke, MI, 30 days after carotid artery stenting. That drop has been, over time, what you would expect with any new technology. As patient selection, technique, devices have improved, outcomes have improved as well, and that's exactly what you would expect. With that in mind, though, if you look at every single randomized trial that has been done looking at carotid endarterectomy as compared to carotid artery stenting, we find one thing in common. Death is equivalent, major stroke is equivalent, but minor stroke has always been higher for carotid artery stenting as compared to carotid endarterectomy. The question is why? And this transcends devices, transcends continents where the procedures have been done. It's always been the case. So in order to understand that, we have to dive into why strokes occur in the first place during carotid artery stenting. And broadly, those can be categorized into 3 buckets. One is during access, one is during the carotid stenting procedure itself, and then there's post-procedure out to 30 days. We know from mathematical calculations that access-related strokes are probably in the 15 to 20% because we know how many occur on the contralateral side during carotid stenting, so approximately the same ones must be occurring on the ipsilateral side because of access-related issues, so that's about 15 to 20%. We know that post-procedure out to 30 days, it's about 5 to 10% as well. The majority of strokes occur during the procedure itself, and during the procedure itself, which has multiple phases, post-dilation appears to be the time where the majority of the risk occurs. That's when we do these procedures, patients become symptomatic, they drop their duckies, they start yawning, become aphasic, and they sometimes improve, sometimes they don't improve, and that's where things really seem to be happening in terms of that risk. And why is that? Well, it's because we're taking that stent, which is a self-expanding stent, and using a balloon to then push it open at high pressure. And as that balloon comes down, plaque extrudes through the stent struts, goes upstream, and even if you have a filter in place, the filter may be overwhelmed. Plaque and embolic particles may go around the filter, and those embolic particles get to the brain, and those are probably the ones that cause minor stroke. Big ones aren't getting there, therefore major stroke is protected or prevented, but minor stroke still occurs. And in fact, post-dilation has been associated as an independent risk factor for stroke and death after carotid artery stenting. So what I'll be talking about today are the technologies to reduce this risk of minor stroke. How can we get this minor stroke risk, which has been our Achilles heel, down to an acceptable or to a 0 level? And that is through improved embolic protection devices, improved stents, dual-layered stents, and better techniques in terms of access. Those are 3 things I'll be addressing. I will not be addressing TCAR. Obviously, that's a huge field, but there's going to be plenty of talks after this on TCAR as well, so I'll reserve information on those to those talks. The first device here is the Paladin balloon. This is a balloon designed specifically for post-dilation. It's a balloon, just like any angioplasty balloon, but has a filter distal to the balloon and proximal to the end of the catheter. The filter comes in a baseline closed position, and the physician can activate a knob in order to open up the filter. You do your procedure like you normally would, put the post-dilation balloon in the stent after the stent's been deployed, turn a knob, the filter opens up, and it opens it to the size and shape of the vessel, therefore creates a full seal. And the filter itself has 40 micron pores, thereby protecting against even the smallest particles. This was studied in the Paladin registry initially, 5 centers in Germany. Right there you can see the actual filter with the markers around it, taking the shape of the vessel. Once the filter is opened up, the balloon is inflated, then the balloon is deflated. Any particles that are released are captured. The filter is then closed down and pulled out. A study done in Germany that I just mentioned allowed physicians to use any stent they wanted, any primary embolic protection device they wanted. The only thing we asked them to do differently was to use this for post-dilation. This resulted in 0 procedural strokes. There was 1 stroke at day 12 in a patient who did not take DAPT and ended up with stent thrombosis, which then resolved with thrombolytic therapy. So it appeared there was some benefit here of using this just during post-dilation. A filter analysis was done of this integrated filter, and it was interesting that 90% of the particles that were caught in that filter were less than 100 microns, which is interesting because currently available distal filters all have filter pore sizes between 130 to 180 microns, suggesting that maybe these smaller particles are getting through, and that may be partly responsible for the risk of minor stroke that seems to be persistent with carotid artery stenting. DW MRI was also looked at in pre and post MRIs that were done in these patients, and the incidence of new lesions was 21.3%, which is really a low incidence and comparable with endarterectomy. And the size or the mean lesion volume was also very low at 0.01 centimeters cubed, all suggesting that the embolic debris was really being prevented from getting into the brain at the time of post-dilation. We know that these embolic particles are important, not just because they reduce the risk of stroke during the procedure, but more and more data suggests that microembolic particles that get to the brain, even if they don't cause stroke, over the long term are responsible for cognitive decline in these patients. This was then, this has evolved from a 2-in-1 device with a balloon with a filter to a 3-in-1 device where it now includes a stent. It's a new stent which is closed cell but has optimal flexibility as well. This is currently not FDA approved, but this 3-in-1 device was used in a study called the Performance 1 study. This was 67 patients in Europe, 9 sites, and this was done with 1-year follow-up, and there were 0 strokes at 30 days, 6 months, and at 1 year. In this pilot study with 67 patients. So that led to the Performance 2 study, which is a pivotal trial in the US, which is about 6 patients away from completion. And Peter and PK here have been enrollers in that trial as well. So we look forward to the results of that when they come out a year from now. Moving on from that, when you look at stents once they've been deployed, and you look at open cell stents versus closed cell stents, and you look at them with OCT, you find that plaque protrusion after stent deployment is an issue. And when you examine these stents, it appears that there's a larger incidence of plaque protrusion with open cell stents as compared to closed cell stents. This makes sense because the cell sizes are smaller with closed cell stents. And in this one particular study, a small study, but there was 61.5% incidence of plaque protrusion with open cell stents and 17.6% risk of plaque protrusion with closed cell stents, suggesting that maybe these events where there's protrusion and embolization of these particles post-procedure may be responsible for some of the risk of stroke. Now, when you look at large registries, these registries are many years old, but the exact registry which looked at the exact closed cell stent, the capture registry which looked at the Acculink open cell stent, there were no differences in terms of outcomes in symptomatic patients or asymptomatic patients. But this hypothesis still remained that maybe some of the risk of stroke post-procedure is because of embolization of particles. This is another study, just 124 patients, but looking at patients undergoing carotid artery stenting with MoMA or with Gore flow reversal, so reversal or cessation of flow. And regardless of what type of stent was used, open cell or closed cell, the risk of stroke was 0.8%, or really a low risk of stroke, suggesting that it's really procedural embolic protection that's important and less so stent design that's important. But regardless, because of this concern of embolization of a plaque through the stent struts post-procedure, the hypothesis was generated that what if you put an extra layer around the stent and create dual-layer stents? Would that reduction in protrusion or plaque help with reduction in embolization during the procedure and post-procedure as well? And 3 companies have come up with stents that have designed stents with double layers. One is Inspire MD with a C-guard stent. The other is Terumo with a road saver stent, and then there's Gore with a scaffold stent. If you look at these stents, the mesh that covers them is different. The C-guard stent has a PTFE mesh with 165 micron cell size. The Terumo has a metal mesh which has a 375 micron cell size, and the Gore scaffold has a cell size of 500 microns. And as you can see over here, this is much smaller than what you would see in a typical closed cell stent or an open cell stent. These have been studied. There's a lot of data OUS. This is just a representative sample. The Iron registry looked at the C-guard stent, 200 patients with a 30-day stroke rate of 2.5%. The ClearRoad registry looked at the road saver stent, 100 patients with a 1% 30-day stroke. There's been other studies like this OUS as well. Interestingly, there is a randomized study that looked at the C-guard mesh-covered stent as compared to the Acculink open cell design stent. A randomized trial, 50 patients in each arm. The incidence of new lesions by DW MRI was the same, about 50% each, but the total lesion volume was much lower with the mesh-covered stent, with a 78.4% reduction in total lesion volume immediately post-procedure with the mesh-covered stent as compared to an open cell stent. And at 30 days, even a larger difference of 92.3% reduction in total lesion volume with C-guard as compared to Acculink. So very interesting, and remains to be seen whether this translates to an improvement in outcomes as well. In order to look at improvement in outcomes, there's 3 ID studies that have been performed. There's a Gore scaffold study which is completed, and the Gore scaffold stent is already approved by the FDA, but Gore has decided not to commercialize it for business reasons. The Terumo Confidence study looked at the Road Saver stent in an ID trial. That trial has completed enrollment, but has not, the data are not yet available and does not have FDA approval yet. Inspire MD, the Sea Guardian study, is currently enrolling. The only data we have from an ID standpoint is the Gore scaffold data, the 312 patients with an intention to treat analysis showing a 30-day death stroke MI rate of 4.8% and a 30-day stroke rate of 2.9%. But in this study, they found in the first 100 patients there was a high risk of stroke, and when they analyzed those patients, a lot of those patients did not meet inclusion and exclusion criteria. And so a screening committee was formed, and the remainder of the patients had to undergo analysis by a screening committee first. And so once that was done, the event rate went down significantly with a 30-day MAE in a per protocol analysis of 3% and a 30-day stroke of 1.1%. There is some concern of potential higher risk of either restenosis or thrombosis with mesh-covered stents, but these are all anecdotal. There have been some reports of acute thrombosis, but largely these are in patients who are undergoing treatment with mesh-covered stents during acute stroke. So it may be that the presence of thrombus in acute stroke patients creates a nidus, creating thrombus. There's been some reports of instant restenosis as well, but these are anecdotal, and there are no long-term data showing whether or not this has an impact on outcomes. It remains to be seen. And finally, moving on to access. So radial access has now become ubiquitous in coronary interventions. We know the benefits. There's actually a mortality benefit of using radial access versus transfemoral access. There's a decreased incidence of major access site complications, decreased bleeding risk, easier vascular access and hemostasis for obese patients, and obviously decreased time to ambulation as well. Echegoen and colleagues did a retrospective analysis of 382 patients undergoing transradial carotid artery stenting. The success rate was 91%. There was a higher success rate for right radial to right carotid versus right radial to left carotid. There were no bleeding complications, and the 30-day stroke rate was 1.6%. This approach is especially useful in patients with either bovine arches or type 3 arches, somewhere anatomy where you may be concerned that access may be a problem or may create a high embolic risk. The technique is actually not hard. You start with a reverse curve catheter, like a Simmons catheter. As you can see over here, you put that in the ascending aorta, and you pull backwards. Once the catheter is in individual or respective common carotid arteries, you advance an 035 wire into the external carotid artery, use that 035 wire to advance a 5 or 6 French sheath into the common carotid artery, and the remainder of the procedure is done as per usual techniques. Here's an example of a symptomatic patient, left internal carotid artery with a very high-grade stenosis, as you can see over here, almost a subtotal occlusion. And this is an example where all 3 techniques were used that I've outlined today: radial access with a mesh-covered stent and with a balloon with integrated filter. This was done in Europe. You can see over here a 5 French sheath into the left common carotid artery, a mesh-covered stent being deployed, and then a balloon with an integrated filter being used in order to maximize embolic protection. And with excellent angiographic results. Again, this is just one case, but showcasing how using these new technologies, even high-risk patients can be treated with good results. So in summary, carotid stenting technology has steadily evolved over the last 2 decades, and you can see an improvement in outcomes over the last 2 decades. Outcomes can now be expected in the 1 to 2% overall stroke rate, and newer therapies hold promise that this will even be further reduced. And of course, as always, aggressive medical treatment, risk factor modification, patient selection are all critical to achieve the best outcomes on a case-by-case basis. Thank you.